Well, good afternoon, everybody, and welcome to our fifth session of Urology Speaks. My name is Alan Parton, and I serve as the director of the Brady Urological Institute and urologist in chief of the Johns Hopkins Medicine. And in a few moments, I'm going to introduce our speaker for today's webinar, Dr. Marissa Clifton, who will present her talk entitled, "Don't Laugh Too Hard, Updates in Women's Urology." I'm so pleased that you're joining us today for Dr. Clifton's talk about an area of urologic health that can often be overlooked. Yet, stress urinary incontinence is one of the most common afflictions in women's health. Expertise in this area is extremely rare, and the Brady's very fortunate to have on our faculty a dedicated clinician scientist like Dr. Clifton. What makes Dr. Clifton and her team especially effective is their focus on not only treating this condition, but also improving the quality of life for the patient through the powers of education, empowerment, innovation, and compassion. Now, whether you personally benefited from the care of our women's health team, or you're interested in learning more about a new frontier at the Brady, I know that today's presentation will be a fascinating look at this specialty. Now, once again, I'd like to share the story of the Brady's beginning. Philanthropy established our institute in 1915 when Diamond Jim Brady, over my shoulder here, a patient of Dr. Hugh Hampton Young, made a generous gift to build and launch the Brady Urological Institute in Dr. Young's honor. The trailblazing partnership of a railroad executive and a world-renowned physician established the foundation for all that the Brady Urological Institute would come to be and all that it continues to be for our patients today. Now, philanthropy is a part of all that we do here at the Brady, and I know that future support will be of particular importance to continued growth of our women's health program. Now, today's webinar is being recorded and will be made available to you. At the conclusion of Dr. Clifton's presentations, we're going to take questions and ask that you use the Q&A button at the bottom of your Zoom screen to ask a question. We'll try our best to answer as many as we can. So without further ado, I'm thrilled to introduce you to Dr. Marissa Clifton. Dr. Clifton has been a member of our Hopkins family since her early days here at the Johns Hopkins School of Medicine. She completed her urology residency at the Mayo Clinic, followed by a fellowship in female pelvic medicine and reconstructive surgery at the Cleveland Clinic. It is a privilege to have Dr. Clifton back at Johns Hopkins and at the Brady. Dr. Clifton serves as the Director of Women's Health and is a talented surgeon in our reconstructive surgery team at the Brady Institute. She is also the Director of our Urology Residence Program and has transformed the educational experience and culture for our future urologic surgeons here at the Brady. Dr. Clifton is off to a great start, and I'm optimistic she'll make an indelible mark and earn the respect of her colleagues, mentees, students, patients, and the entire field of urology. Marissa, the floor is yours.
Well, thank you so much, Dr. Parton. I really appreciate this opportunity, and it's also wonderful to be introduced by you because I don't think without your support when I was a medical student that I'd be a urologist today. So thank you for that and the beautiful introduction. And to all of those in the audience, thanks for being here. I know this may not always be the most interesting talks, but hopefully you can gain some information from our conversation. So before I get started with my slides, I just wanted to give a little bit of background on why I became interested in the field that I'm pursuing. So I love all of urology. I love prostate cancer. I loved oncology. I loved all of these various fields, but I quickly recognized that there is a need for women to have urologic care. And the more patients that I saw in clinics when I was a resident and as a fellow, I recognized how important my role would be for women. So I still love seeing my male patients, but my real passion is helping women achieve their goals. And so I'm going to be sharing my screen, and I hope you can see how exciting this topic is and maybe learn a little bit of something as well. And again, it is really my pleasure to be here today. So as Dr. Parton already alluded to, we are going to be talking about incontinence today. And there are many different types of incontinence. And honestly, the treatment is varied depending on what we're looking at. So as I bring up my slides, I'm going to talk about stress incontinence today. And so I know it's a little bit of a funny topic, but don't laugh too hard. So this is really going to highlight stress urinary incontinence. So what am I going to talk about? I'm going to talk about what stress incontinence is, and then the diagnosis and evaluation of stress urinary incontinence. I want to highlight our conservative approaches for management, but then want to discuss some of the innovations and the surgical therapies. So in general, what is incontinence? Well, it's the involuntary loss of urine. Interestingly enough, because you have the leakage of urine or the loss of urine, that doesn't identify why it happens. So we're going to talk about some of the scientific reasons and differences, basically by symptoms, and then what's physically going on with your body. So incontinence classification can be based purely on a patient's symptoms. For instance, with stress incontinence, that's the leakage of urine during physical exertion. So you're bearing down, you're coughing, you're walking, you're going upstairs. And it really occurs when there's an increased pressure on the bladder and a leaky sphincter muscle. So here's a diagram. And you can see that that pressure basically pushes that urine out of the bladder and out of the urethra. And so there are different reasons that that can happen, and that would be the pathophysiology. So when we're talking about symptoms of other types of incontinence, for urgency incontinence or something called overactive bladder, this is the involuntary leakage of urine, and it's usually associated with the sensation of having to run to the bathroom. Not always, but usually. There is something called continuous incontinence. So that is just a constant leakage of urine, and you may not have a sensation that you have to go to the bathroom. But a lot of women experience what's called mixed incontinence. So they have a little bit of the leakage with laugh, cough, and sneeze and bearing down, but they also have leakage with the urgency to run to the bathroom. And there's this other very annoying concept that we see in urology, which is called nocturnal enuresis, or essentially leaking of urine while you're sleeping at nighttime and you have no awareness of it. And this is a little bit more challenging to treat, but it's certainly something that's very bothersome for women. Now, when we look at what's actually going on with the body, that's called pathophysiology. We're going to kind of talk about incontinence as it relates to what's going on with your body. So there's this idea of what's called intrinsic sphincter deficiency. So the sphincter muscle it's called the external sphincter, is a muscle that kind of contracts and holds the urine in the bladder. Now, if it is loose or weakened for some reason, that urine can slip by. And so when people have a sphincter muscle that doesn't work as well, your channel could be wide open. So in this picture, you see that the sphincter is nice and closed, but in this picture, it's open in a straight shot out. And so that's called intrinsic sphincter deficiency. Sometimes the pelvic floor muscles aren't supporting things the way that they should be, and that's called urethral hypermobility. So basically the urethra is very flexible and we don't have the support to keep the urine in the bladder. Now, when we think of overactive bladder and you're talking about what's going on with the body, that is a situation where the bladder is squeezing, physically squeezing when you don't want it to. And most of this time, you can't control it. And so the bladder is squeezing and forcing out the urine. When we have a bladder that becomes stiff and isn't very flexible, we can also have issues with incontinence. Now, this situation is very unique and usually relates to patients that have some sort of nerve issue affecting the bladder function. And so when this happens, the bladder is very, very stiff and not flexible. The bladder has to open up and store a lot of urine. And if it doesn't do this, sometimes patients can have leakage. Now, there are a group of patients that just never empty out their bladder. So that type of leakage is called urinary retention with overflow incontinence. So I like to use the analogy of a rain bucket, and the rain is coming in and that fluid is kind of falling over the sides. And so in patients with overflow incontinence, you basically are leaking because your bladder can't hold anymore because it's so full and never empties. So let's go back to the topic of our conversation, which is stress incontinence. So when we think about stress incontinence based on symptoms, this is when you cough, laugh, and sneeze and bear down, and out comes some leakage. When it's The pathophysiology, that can be from either a leaky sphincter muscle or not a strong sphincter muscle, or failure of support of the pelvic floor. So how common is stress incontinence? Well, this statistic is a little bit old. I would say that more than 20% of women have experienced some form of stress incontinence in their lives. We want to know why it's happening. Well, some of the causes are pregnancy, vaginal deliveries, but that's not the only reason that it could happen. Sometimes extra weight, such in patients that have a lot of obesity, or in a chronic cough situation. So when you're coughing all of the time, putting that additional pressure on the bladder. And unfortunately, there's a genetic component that we don't yet quite understand. And when you see someone about these issues, they're going to talk to you about your story so that they can figure out what type of leakage that you have. So for instance, they're going to discuss, when did this start? How severe is it? Do you have any other urinary symptoms? They may want to know how much fluid you're drinking, when you're drinking it, and if there's a bladder irritant involved, such as caffeine or artificial sweeteners. They'll not want to know your medications, your delivery status, and if you've had any history of pelvic surgery. Now, how do we evaluate it further? We're going to do a physical examination, and this is incredibly important to do a pelvic examination because much of what we do depends on what we're finding related to the anatomy. So I'm going to look and see if a patient has the organs of the behind the vagina kind of falling downwards. That's called pelvic organ prolapse. I'm also going to look at the lining of the vaginal tissues, the skin of the vagina, and see if that's healthy. And then I'm going to have my patient cough and bear down to see if I can see how much leakage there is. In terms of testing, sometimes we have patients come in with avoiding diarrhea. This really helps us understand what patients are going through on a daily basis. We will get a urine test frequently, especially if there are urgency or frequency symptoms, to make sure there's not a bladder infection. And importantly, we make sure that bladder is emptying, so we do a quick scan in the office. The most important aspect of treatment, which I'm going to discuss in a few minutes, is making sure that we know what's bothering you. So I think this is a very personalized approach to your care. Our treatment is entirely based on the patient's degree of bother. So it's not what I think and it's not what someone else thinks. It's our conversations with our patients. Now, what can we do that maybe isn't a surgery or a medication or some sort of intervention? Well, there have been studies looking at behavioral therapy. So behavioral therapy, we're talking about modifying our activities and our fluid intake to kind of help stop the incontinence based on our fluids or our foods that we're taking in. There is a thought that if you time your bladder emptying, that potentially you can improve some of your leakage issues. However, when we did a meta-analysis through a Cochrane review in 2004, we did not find sufficient evidence that timed voiding could improve stress urinary incontinence. Now, I do like the idea of avoiding diarrhea after you've started treatment because this really provides feedback and you can see your journey, what you started at and where you're going and what you're at currently. It really monitors our progress. Now, physical therapy, I think, is a wonderful tool that is maybe underutilized. This is the natural approach to improving your leakage symptoms. So pelvic floor physical therapy isn't as easy as reading a handout and just following a few steps. It's actually incredibly technically important to do correctly. So we have very thoughtful specialists, the pelvic floor physical therapists, that are trained to teach our patients how to contract the appropriate muscles and ensure that their pelvic floor is healthy. So we know pelvic floor physical therapy, again, not just Kegels, not just one approach, can improve not only stress incontinence, urgency incontinence, but it can improve both. And when we look at studies in motivated patients, it can improve incontinence by up to 80%. So when you look at our American Urological Association guidelines, pelvic floor physical therapy is the first line treatment for both stress incontinence and overactive bladder or urgency incontinence. And when people say it doesn't work, a lot of times it may be failure to understand how to do it correctly. So we know verbal instruction is insufficient, and it does take a while for these exercises to result in a change in urinary symptoms. So don't get discouraged if at the first week you don't see a drastic improvement. It may take up to 6 to 12 weeks to really see a benefit. I wanted to highlight this website for maybe our participants that are across the country, because sometimes it's very challenging to find a good pelvic floor physical therapy therapist. And so this is a resource where you can go on the website, find your location, and maybe find your symptoms to locate someone close to you. It is so important to find a good pelvic floor physical therapist, or you may have issues and not really get the best benefits. Now, something else that we can try that is non-surgical is weight reduction. We know in a New England Journal of Medicine article that weight loss can be used to treat both forms of incontinence. So there was a prospective randomized trial that was performed, and they were able to find that even with a small reduction of weight, 8%, there was a significant improvement in urinary incontinence symptoms. So we talked about physical therapy, we talked about weight reduction. There are also other mechanisms of improving stress incontinence. So there are various devices that are available on the market. If you see a pelvic health specialist, they may be able to fit you with an incontinence pessary. This is a ring that goes into the vagina and pushes support against the urethra to close it. And patients are able to pull this in and out and put it back in and help with incontinence, especially during exercise. There are also specialty designed tampons, and these put pressure against the urethra tube and help with the leakage with laugh, cough, and sneeze. And interestingly enough, there's a device that you can actually insert into the urethra, and this can help prevent leakage. But you can imagine that it takes a very special patient to do this routinely. Very frequently, a patient will come to my office and say, what medicines can I use? How can I improve my symptoms through medication? Well, for stress urinary incontinence, there really are no medications that are FDA approved for the treatment. So I know it's frustrating, but if you think about it as a mechanical issue, it makes sense. And so the future is bright, and we may have something in the near foreseeable future, but right now we don't have anything to treat stress incontinence. There are medications, however, that treat overactive bladder. And again, a lot of women have both types of incontinence. There's something new that has come out on the market, and this is a non-surgical radiofrequency treatment. Basically, a probe is placed into the vagina and the tissue is kind of warmed up. And the thought of how this works is basically it stimulates collagen remodeling and neovascularization. And the hope is that this may be something that can improve stress urinary incontinence. Unfortunately, the literature hasn't really shown drastic improvements with stress incontinence through this therapy, but I think there's still a lot left to learn. Again, big groups of people are needed to determine if this is going to work long term, but right now I think smaller studies have shown some promise, but it isn't convincing yet. Now, let's talk about surgical treatments, because that's a mainstay for patients that have maybe failed the behavioral or the physical therapy approaches. And I'm going to talk briefly about bulking agents, slings, and some other treatments that have been available historically. So what is a transurethral bulking agent? Well, essentially, you can see over here that the urethra tube is open, the sphincter is open, and it's not doing its job of holding back the urine. Now here, injectable material has been placed submucosally to kind of close that urethra down. So the idea is that we bulk the urethra and kind of create a road bump so that maybe the urine doesn't leak out. In the past, it maybe hasn't worked quite as well, and we use this technique for patients that may not be surgical candidates, for women who want to have biological children still, and maybe those that have had previous stress incontinence procedures that haven't worked. The reason it's not a mainstay for our healthy patients is that it's maybe only 60% efficacious at 2 years. So I'm sure many in the audience have heard about synthetic midurethral slings. So The synthetic material is a piece of mesh, and this mesh is a very thin ribbon. So you can see here, it is very thin, but it is, in fact, a synthetic man-made material. So we can place these various ways, and standardly, what has been known long-term is the retropubic approach, and that's been out for decades, and it's probably a gold standard approach for stress urinary incontinence. The other way to place this mesh is through the obturator foramen. So it's the same type of mesh, but it goes through the obturator space, and it doesn't go behind the pubic bone, and this is also a very common treatment. But because it is a foreign body, it is a man-made material, it can have what's called mesh extrusion. And that's where the mesh goes through the lining of the vaginal tissue. And when that happens, there's a simple procedure to excise that exposed mesh, and we can leave the majority of the mesh in place and the benefits of the mesh as well. But that risk is there no matter what you do. And this is a common issue that I face with my patients, the concern about the FDA actions related to mesh. Well, many of the issues with mesh have involved transvaginal mesh kits for prolapse, and it actually has been a very significant issue for a lot of women. So the transvaginal mesh kits have actually been removed from the market because they have been deemed somewhat experimental and maybe had an unacceptable rate of complications. Now, synthetic midurethral slings do use that mesh material, but in the FDA warning are not included. So it is still safe and effective, and multiple organizations have said that it's the gold standard treatment for stress urinary incontinence. So patients that maybe don't want to have synthetic material for their slings can have their own body tissue used for slings. So an autologous pubovaginal sling is where we take a piece of the strength layer of the abdominal wall or the fascia lata right here, and we use that to construct a sling. So it is placed very similarly to the synthetic sling, but there is a higher chance of not being able to empty the bladder as well, and it does require an abdominal incision or an incision on the leg. It can be a little bit more challenging to recover from this procedure than the synthetic midurethral slings. But these autologous slings have been used for decades and have returned to favor in certain groups because they are not man-made materials. There are other treatments that are available. Classically, when you have an abdominal procedure, they do something called the Birch procedure, and this is an abdominal approach to treat incontinence. Sometimes people have used cadaveric tissue, so fascia harvested from donors. Now, the literature has shown that maybe this doesn't last quite as long as using either your own tissue or a synthetic material. There's this new concept of a mini sling, which is a shorter piece of mesh, and the way that it is placed is through a single incision most frequently. These slings have been utilized pretty broadly, but we have seen that there may not be as significant of a long-term benefit after a mini sling compared to the retropubic or the transobturator slings. Excitingly, we have a new FDA product that's on the market, and this is polyacrylamide hydrogel. So it is a type of bulking agent, but is placed slightly differently. And the other great aspect of this is that it is very biocompatible. So some of the other complications we face with bulking agents, we may not face with this. So you can see here that the bulking agent is placed almost right underneath the mucosa. So it's not all the way back here at the bladder neck like our classic bulking agents are placed. So therefore, maybe less material is needed and you get a more consistent bulking of the urethra. Now, this therapy has actually been around for quite some time and has been utilized in Europe extensively. It really has a very low complication rate, and most patients can go back to normal activities the same day or a day later. Now, what are some of the complications from the traditional bulking agents? Well, as you can see here, this is an extrusion of the material that has been implanted. So that can happen over time where you use a more permanent material and it can go through the lining of the urinary tract. Another tough complication to deal with is when these bulking agents calcify. And in this diagram, this is supposed to be the pubic bone, and all of this white right here essentially is calcification. So a bulking agent has been replaced by a calcium deposit, and these can be challenging to deal with. So the real question is, where does our future lie? I talked a little bit about this new bulking agent that we have here in the United States, but it's not really new. It's been around for 15 years. I think a very exciting prospect are our autologous muscle-derived stem cells for treatment of stress incontinence, and these are still currently under investigation. So what this is taking your own stem cells from the muscle, and then through a very fancy process by our wonderful companies that we collaborate with, they essentially get muscle-derived stem cells, and these are injected directly in the sphincter to improve incontinence. Currently, we don't have it approved, but the future looks bright in terms of an opportunity to actually regrow this tissue to help with stress incontinence. I think one of the most important aspects to highlight is that, as you've seen, we've had very few advancements recently in stress incontinence, and even our new FDA product has been on the market in Europe for a decade and more. But because we have a concern about mesh complications, I think it's even more important to focus on non-synthetic treatments for stress incontinence. So there's a lot that's in development. There's not a lot of additional opportunity available, but look at this statistic. Only 7% of NIH urology grants are awarded for incontinence, and this has been over 10 years. So we have a huge focus on cancer, but we really don't have as much of a focus on the benign urology that affects our women every single day. So I just wanted to highlight, the take-home messages, and we've discussed a couple of very interesting ideas. But I want everyone to realize that urinary incontinence is an incredibly common problem, and you have to differentiate why a patient has incontinence. If they have stress incontinence, we've just learned about the different ways this is evaluated and treated. But if they have overactive bladder or if they have overflow incontinence, the treatment is quite different. Importantly, as a clinician, I have to respect what my patients are most interested in pursuing. And I think this is the most important aspect of what I do for incontinence. We have a conversation and I treat incontinence based on the degree of bother of my patient and also what they would like to proceed with. And philanthropy is incredibly important to the future of the field of benign urology. We do not have a lot of efforts currently or monetary grants focused on benign urology, but I think this is an increasingly important aspect of urology. And I have a few more minutes that I wanted to talk about some common questions that I face in the office. So I get questions about every aspect of female health that you can imagine. And I think that a lot of people have done significant research. They have read materials. They have a lot of very, I think, profound questions. And so I was going to discuss a few of them before we go to our Q&A. So a very common question I have is, will estrogen help my leakage? And so what they're usually talking about is something called vaginal estrogen. So there are different forms of estrogen. One is the oral supplement that is usually given around menopause to help with some of the systemic or body symptoms that are a result of going through menopause. But vaginal estrogen is a local therapy, and it's essentially estrogen that's placed into the vagina several times a week to help preserve the vaginal epithelium and pH. So vaginal estrogen is very safe, it's effective, but it doesn't cure everything. And so for stress urinary incontinence, we really don't have any evidence that vaginal estrogen therapy will help with this. There is some suggestion that it could help with urgency and frequency symptoms from overactive bladder. When we look at estrogen in postmenopausal women, we find that estrogen is significantly better than placebo, improving overactive bladder symptoms. But it's not the oral estrogen, it's the estrogen that is applied vaginally. And interestingly enough, when I have patients that are on oral estrogen, I have to supplement with a vaginal estrogen therapy because the estrogen doesn't get to everywhere it needs to go. There are some contraindications for vaginal estrogen, and in patients that have had active DVTs, I hold off until their hematologist says it's okay. Now there's concern. Vaginal estrogen, does it cause heart attacks? Does it cause cancer? Is it going to cause a problem? Well, vaginal estrogen applications really don't get absorbed systemically. They work locally. So I think they're very safe. Now in patients that have active vaginal bleeding and they're postmenopausal, it's very important they have a thorough workup with their gynecologist, because you don't want to give estrogen therapy if there's an endometrial issue or a uterine bleeding issue. So what are the side effects of vaginal estrogen? Well, you can have some local symptoms. You can have some irritation that's usually from the cream. So it's not the estrogen itself, but from the cream. Sometimes when people have been away from estrogen for such a long time, they can actually have a little bit of an absorption throughout their body before their tissues in the vagina thicken. And so people will get an occasional hot flash or maybe some breast tenderness. But if it's used consistently, and I tell my patients, you start with a little and you build it up. If it's used consistently, those side effects will go away because very little estrogen will get absorbed into the bloodstream. So I think this is really important to highlight. Estrogen in postmenopausal women, when it's taken orally, has some very significant concerns, including heart attacks, cancers, and other blood clots. But vaginal estrogen, however, is very safe. And it's not just me saying this. The American College of Obstetrics and Gynecology says it's safe and effective when you have a conversation with your doctors. And so I do have patients with breast cancer that are actually using vaginal estrogen to help with some of their local symptoms. And this is done under the close watch of their gynecologist, oncologist, as well as their urologist. So we really don't see an increased risk with vaginal estrogen among women undergoing treatment for breast cancer, and it is an option. So in my patients that are healthy and my patients that are active, I think it's a great opportunity to improve some of the local vaginal symptoms that they have. Another question that I get asked is, do I get urinary tract infections because I have leakage? I can't tell you how many times I've seen women in my office who are completely put together, incredibly clean. I mean, their makeup is better than mine. They look wonderful. And they're worried that the incontinence that they experience is what's causing their urinary tract infections. And unfortunately, they've gotten this impression, I think, by the things that doctors have said or clinicians have said, or maybe what the internet has said. So urinary incontinence does not cause urinary tract infections. We know there are patients that are predisposed for infections, and those patients will get urinary tract infections regardless. Incontinence can be life-altering, but I don't want my patients to have to worry about the additional struggle of urinary tract infections. So no. Your leakage is not what's causing your urinary tract infection. There actually are a lot of myths associated with why women develop urinary tract infections, and I just like to kind of dispel a few of those myths. So women think it's because I wipe wrong, and they've been told wipe front to back, and that's how you prevent UTIs. The meta-analyses have not shown that to be true. People urinate before and after sexual activity, hoping that that will decrease the risk of urinary tract infections. And again, the literature hasn't really borne that out. People don't go into hot tubs or take baths because they're worried about getting a UTI. And that also has not been shown to be true. Tampon use and douching as well. I think that, those activities may not be indicated for other reasons, but they're not causing your urinary tract infection. And because we have just a few more questions to answer before we get to your questions, I'd like to talk a little bit about when to treat bacteria in the urine when you have no symptoms. So patients come in, they get a positive urine test, and they say, I need to have my urinary tract infection treated because I have a positive test. Well, actually, you shouldn't be treating the bacteria in your urine if you have no symptoms. And why is that? Well, actually, if you think about it, there are a lot of women in the world that have bacteria on their skin. All of us do, actually, men and women. Bacteria lives on the skin in the GI tract, and it's called colonization, has an important role to keep our bodies healthy. Well, similarly, bacteria can live in the bladder and not cause any symptoms. And in that case, it shouldn't be treated. And just one more question before we go to the group. When do you seek treatment for stress urinary incontinence? Well, many women, I think, don't talk about this, and they're embarrassed. And some of the statistics I showed, 10 to 20%, but I think even more women experience this throughout their lives. So when do you need to seek treatment? I tell patients, if you have questions, if you have concerns, and if you don't know what's going on, you should seek the opinion of someone who can help you decide what the best steps are for you. And this may be, I just want to do some physical therapy. I want to make sure I have the diagnosis. I want to make sure my bladder is emptying. So you should see someone and have a conversation. Do you have to go straight to surgery? Absolutely not. And in fact, a lot of us would recommend trying pelvic floor physical therapy and other treatments before stepping on to the surgical treatment algorithm. So I just want my patients listening and the women in the audience listening that when you have stress incontinence, you should only be treating this when it bothers you or when you have questions. So don't have it treated if you're not having bothersome symptoms. So I think that we are running close to time with the Q&A. And I want to thank everyone for their attention and paying, taking a little bit of time out of their day so that they can learn a little bit more about stress urinary incontinence and how we treat it and how we manage it. So thank you very much for your attention, and I look forward to hearing from the audience.
Thank you so much, Dr. Clifton, for highlighting such a very, very important topic, yet that's often overlooked. We are now ready to pose the audience questions to Dr. Parton and Dr. Clifton. Just as a brief reminder to all of our participants, please use the Q&A button at the bottom of your Zoom screen to submit a question to the panelists. We're definitely going to do our best to address as many as we can this afternoon, and we already have a couple here for you, Dr. Clifton. Do you have any comments regarding the relationship between urinary incontinence and normal pressure hydrocephaly and pH?
So I think that is a really important idea to discuss, and I didn't get a chance to talk about it in my presentation. So there is a very important communication that happens between the brain and the bladder. And in patients that may have issues that affect the nerves. So normal pressure hydrocephalus is buildup of pressure on the brain. And as you can imagine, the brain is basically the computer for the body. So there are a lot of nerves involved. So if there's an increase in pressure in the brain, that can affect how the nerves are functioning and how they're sending the information to the bladder. So yes, I do think that there can be quite an impact based on normal pressure hydrocephalus. Now, the talk that I just gave is kind of the straightforward stress incontinence patient. It's the patient that has laugh, cough, and sneeze leakage without nerve involvement. If you have a nerve issue that's affecting how the bladder functions, that's called neurogenic bladder. It doesn't tell you how it's being affected, but it is an idea. And when nerves are affecting the bladder, there's a different way we work them up and we treat them. So I would encourage anyone that has nerve issues and bladder problems to seek the advice of a specialist if there are concerns from the lower urinary tract standpoint. So a patient with normal pressure hydrocephalus may require an additional workup than what I outlined previously.
Wonderful. Thank you, Dr. Clifton. For our next question, do you think stress urinary incontinence could be caused by fertility drugs?
Oh, goodness. Well, I think there are a lot of different things that fertility drugs do to the body. They change, your composition of your fat potentially. They change your density of your muscle and your bone. There are a lot of downstream effects. And I think that's a very interesting question that we should probably research a little bit further. But we do know that hormones, like I highlighted, can affect the vaginal tissues and then potentially affect the bladder. I like to tell patients to have a really thoughtful thoughtful conversation with their infertility specialist so that they know what to anticipate. Now, more frequently, younger women are going through fertility treatments. And in that case, I think it's a great chance, if you're having urinary symptoms, to see a specialist. And then they may very well recommend that you go see a pelvic floor physical therapist. Interestingly enough, in a lot of European countries, women that deliver or are pregnant are seeing pelvic floor physical therapists so that after they deliver, they can be very aggressive with their pelvic floor health. I don't think we're quite there in the States, but I think it's an avenue for the future. And so whenever I see a younger patient, I'm very active to get them involved with the pelvic floor physical therapist. So I'm a surgeon, but I don't know all of the ins and outs of physical therapy related to the pelvic floor, but I'm so fortunate to have some amazing colleagues that know much more about it than I do. So the key is I can direct my patients to these very thoughtful clinicians that help them understand their pelvic floor health a little bit better. And so we work together to create a collaborative approach. And so in a younger patient who's having some urinary symptoms while being on fertility medications, I think it's a great opportunity to see if you have a good physical therapist nearby, but first make sure to have a conversation with your doctor.
Thank you. For your next question, as a male living near Sibley Hospital, which pelvic floor physical therapist would you recommend?
So we have some amazing groups that are in the DC area. Because I'm here in Baltimore, I know most of the physical therapists that are nearby. We do at Hopkins have a wonderful pelvic floor physical therapist, I think at Sibley. I think she's stationed at Sibley. Many of our pelvic floor physical therapists are women. However, they treat men. And so I think that they have a very unique perspective. They're very sensitive and understanding. So I would reach out to the physical therapy department at Hopkins at Sibley and see if they have someone available, because I've had great success with the group there. I have many patients that come to my office and they feel very isolated because of the symptoms they're experiencing. I tell patients that as we get older, your risk of having incontinence does increase. However, the types of incontinence change. So we find women that have stress incontinence that usually kind of peaks in the middle age range. So after having deliveries, 40s and 50s, and then it can kind of get a little bit better, or it may not be as major of a complaint. But then as women age, the overactive bladder incidence tends to increase. So we have these patients that have had significant stress incontinence, maybe after deliveries, and that gets a little bit better as they age, but then they're dealing with a different problem, which is overactive bladder. So when I meet with a patient in the office, I say, everyone is different, so I don't know how to define normal. Again, the key is how much it bothers you. I don't want my patients to go through a therapy or a treatment if it is not something that they're interested in because they want to just because they want to be normal. If it is bothersome, we should have a conversation about how to fix it. But I don't want any of my patients to feel that something is abnormal because it's happening, but I don't want them to have to live with it either if it's bothering them. So I would say age does predispose to certain incontinence, but the degree of bother is when we treat it.
Dr. Clifton or Dr. Parton, could you discuss the relationship, if there is one, between incontinence and head injury?
Okay, well, so Sushmi, sorry, I missed that little bit of it. The relationship between traumatic brain injury and incontinence?
Correct. Is there any correlation either way? Or I guess TBI causing incontinence?
Yes, there absolutely is. As we talked about, that communication from the bladder to the brain is incredibly important. And when that pathway is disrupted, because you may have a brain issue going on, or you could have a spinal cord issue going on, or you can have a peripheral nerve issue going on, so the sacral nerves going to the bladder. And based on the degree of where those injuries occur, patients will have potentially differing symptoms. And also if the injury is a large injury or a small injury, a complete injury or an incomplete injury. So if you had a patient that came to your office and they and they said something like, I have multiple sclerosis. I can't guess what their urinary symptoms are going to be because those lesions can occur multiple places throughout the central nervous system. Now, with someone who has traumatic brain injury, there are a lot of different factors to weigh in. If it's a long-standing issue and their ability to take care of themselves on a daily basis is affected, there can be many reasons why incontinence is happening. Now, if they've gotten back to normal activities and they're back to their usual activities and still having bladder symptoms, I do think they should be evaluated by a specialist because it's so important to ensure that there isn't something else that you're missing, such as an inability to empty the bladder, such as a bladder that is irritable, and it's irritable because there's a nerve issue. So I think in patients with a traumatic brain injury with bladder symptoms, they should have a thorough evaluation by a urologist that they trust.
That was a great answer, Marissa. We actually, just like we have urogynecologists, there are neuro urologists. We have one on our faculty, Dr. Jacek Mostwin, and they work very closely with neurologists for things such as Parkinson, MS, to try to figure out if we can help them with their urinary symptoms that are caused by their brain injury.
Thank you both, Dr. Clifton and Dr. Parton. Our next question, what other conditions do urologists treat for women, or is it pretty strictly heavily focused on urinary related issues?
Well, that is a really important question. And one of the reasons I went into urology is that women have many of the same organs as men. So an interesting story is when I was younger, I told my mom I was going to go, I think Dr. Parton may know this story, but I told my mom I was going to go into urology, and she said, I thought you wanted to be a surgeon. Well, urologists are surgeons, and we deal with many different organs. So the kidneys, so women have kidneys and they have kidney issues. They have kidney tumors, they have swelling on the kidney, they have kidney stones, we have ureters, we have urethral issues that need to be addressed. We have bladders, we have urethras. We also, as urologists, deal with systems that are not directly in the urinary tract, but next to it, like the adrenal gland or the lymph nodes beside the kidney and the ureter. So there are many conditions that women may have that are unrelated to the bladder or incontinence. And we have wonderful urologists here at Hopkins that treat all of those organ systems and all of those issues.
Wonderful. We have time for a few more questions here. Dr. Clifton, are there any foods or liquids that could make stress urinary incontinence worse?
That is a great question. So stress urinary incontinence, as we talked about, is maybe from that leaky sphincter muscle or failure of support of the bladder. Now, overactive bladder or an irritable bladder that wants to squeeze when you don't want it to squeeze, that can actually be affected by the food that we eat and what we drink. So we do know that alcohol, artificial sweeteners, sometimes citrus, and sometimes other spicy foods, things like that can irritate the bladder and worsen overactive bladder symptoms. Now, from stress incontinence standpoint, we haven't classically talked about foods or medicines really affecting stress incontinence, but I can tell you in my patients who take diuretics or who drink, if they're drinking alcohol, they can actually get some worsening of those stress incontinence symptoms. Specifically with diuretics, you're flooding the bladder with a bunch of fluid, so you're filling your bladder quickly. And so they may have more issues with stress incontinence from that perspective.
Great. For either Dr. Parton or Dr. Clifton, is there any correlation that you found in research between stress urinary incontinence and urological cancers?
So I'll start with female, and then I'll let Dr. Parton if he knows of anything in the literature related to men. But for women, I would say there isn't really a direct correlation to cancers and stress incontinence. There are a couple exceptions to this, however. So if I have a patient who may have a very large tumor in their abdomen or pelvis and has some stress incontinence, that can improve if you get rid of that large mass or something like that. Certainly if patients have had histories of radiation for maybe cervical cancer or other reasons, they can have stress incontinence because the radiation, although it treats the cancer and improves that side of things, it can actually kind of cause that urethra tube to be stiff. So I would say sometimes the treatment of cancers can result in stress incontinence in women, but don't necessarily the cancer itself cause those symptoms. And Dr. Parton?
Well, in men, it's similar to that. It's either something in the bladder near the sphincter or in the prostate near the sphincter that can lead, related to the cancer, to stress urinary incontinence. It's usually related to what we've done to treat the patient. As Marissa mentioned, removal of the prostate can lead to incontinence. It's not necessarily stress urinary incontinence, but it can lead to that. But the cancer itself, other than these obstructions or changing of the anatomy, that doesn't really relate to it.
Got it. Are there things a patient could be doing while pregnant, for example, to limit the risk of urinary incontinence?
Well, I think that's a really important question. So I think being proactive is key. If you are able to, before pregnancy, meet with a pelvic floor physical therapist to kind of learn basic tricks and techniques to improve, maintain your pelvic muscle strength, I think that would be ideal. Now, pelvic floor physical therapists are cautious about doing a lot of exercises when women are actively pregnant because there's a baby and we want to make sure the baby's healthy. So if you're thinking about getting pregnant and if you want to learn how to do the exercises correctly, I think it's a wonderful time to meet with a pelvic floor physical therapist. Some patients are worried about the time intensity or how often they're going to have to go or the costs associated with it. Fortunately, for preventative pelvic floor health, I think the number of sessions you need to go to is quite reasonable, maybe just even a couple of times. And pelvic floor physical therapy is a little different than shoulder physical therapy and back physical therapy. You don't have to go 3 times a week, 4 times a week. You maybe just have to go once and then a week later or 2 weeks later again, just to make sure you're doing the exercises correctly. So I think being very proactive about it and learning the exercises is important. Now, if you are developing pain or if you have other symptoms or you're finding that the exercises aren't working, there's a chance that, you've read something and you started trying to follow it off of a sheet, and that's maybe not the best approach. I think at that point, really working with a pelvic floor physical therapist to identify your specific concerns and evaluate your anatomy so that you're doing the right exercises for you, I think that is really important. So I wouldn't have the audience go home and start doing a lot of Kegel exercises or the strengthening exercises, because we actually know in the literature, when you ask doctors to do Kegels, we do them wrong. So how in the world are we going to instruct our patients on how to do it? So I think, Sushmi, the most important aspect is prevention. And if you have a chance before pregnancy to learn some good pelvic floor physical therapy by an experienced individual, I think that's preferred. And during pregnancy, really focusing on your pregnancy and the health of your overall body is so important. Now, that being said, we don't want patients to gain lots of weight and we want patients to stay active. So another really important aspect during pregnancy is staying active, doing some aerobic exercises and doing strength training so that they don't lose that muscle mass. And I think that's another wonderful preventative strategy.
Great. And we have actually the perfect question to end our Q&A session this afternoon. How does the Brady collaborate, or does the Brady collaborate with other departments such as gynecology? And what are we doing here uniquely that isn't being done elsewhere?
So I highlighted a little bit about what we're collaborating with gynecology, and I'll let Dr. Parton finish with maybe some of our other collaborations. But within gynecology, we are very lucky because I'm part of the Female Pelvic Medicine and Reconstructive Surgery Fellowship. So I help with the education of our urogynecology fellows, but we also collaborate, and we collaborate not only clinically, but from a research perspective. And I love the additional insights that my gynecology colleagues bring to my approach to research research in clinical medicine. So I think we are very collaborative. Now, that being said, they all have various strengths, and we do a lot of international health initiatives. I have a colleague, Dr. Grace Chen, who's very active in that role, and that's provided an invaluable exposure of our residents and also the FPMRS fellows to global health initiatives. And so I think, the sky's the limit in terms of the opportunities that our residents and our fellows can pursue here, and our patients get the benefit of having a multitude of different experiences and exposures to ensure that their care is optimized.
We actually collaborate with just about every department in the hospital, but it's quite a unique experience on the Bayview campus, and it's something that was in my vision 16 years ago when I took this position, was to build a female pelvic health center. So if you could imagine, there are urologists, urogynecologists, gynecologists, and colorectal surgeons. It's also part of the problem. They're all centered on the same floor of the same building, using the same procedure rooms, the same clinic rooms, and seeing the patients together. It's been a miraculous discovery that we've worked out here, and I think that does make us unique in the region for sure. And I'm very proud of what they do. So I'm going to go ahead and wrap this up now. I want to especially thank Sydney Marshall. She's been running this from the event center. Those of you that aren't in Baltimore don't realize that we had a horrible storm just before this started. And people's powers were going out, and we were rushing to get new computers, and Sydney's phone went out a few times, but she's kept us on key, and she's working. So thanks, Sydney. And I want to thank Sushmi and the rest of the staff from development for this entire 5-part series. I've done a fabulous job, and I've really enjoyed doing it. Again, I want to thank Marissa for joining us for her presentation and for answering so many thoughtful questions this afternoon. I also want to thank each and every one of you for participating in the webinar and for your continued support of the Brady and Johns Hopkins Medicine. Now, although this is our final Urology Speak session before we break for summer, I'm delighted to share with you that we're planning additional speaker seminars to resume just after Labor Day. So keep an eye on your email for those details, and our best wishes to you all for a joyful, safe, and memorable summer. Thank you very much.